Your body is an assembly of 30 trillion cells, and all of them need oxygen, or else they will die within minutes. Some organisms meet their oxygen demands by passive diffusion, but sufficiently large animals, like humans, need dedicated machinery. For people, this comes in the form of lungs to fix oxygen into red blood cells, blood vessels to facilitate transport, and a pump to power it all, the heart. The heart, or more broadly the cardiovascular system, is the human body's largest failure mode. Heart disease is the number one cause of death in the US, killing 700,000 people per year, and cardiovascular disease is the leading cause of death globally, causing 18 million people to die every year, which is 1/3 of all deaths. This isn't to say that the heart is poorly designed, just that it has a difficult job. Run continuously for tens of billions of cycles, and if there is ever a malfunction that lasts more than a few minutes, everything dies. To understand how malfunctions happen and how they can be mitigated, let's look at the heart structure. Our 4-chamber heart collects deoxygenated blood in the right atrium, uses the right ventricle to pump it to the lungs, collects the freshly oxygenated blood from the left atrium, and sends it off to the rest of the body through the left ventricle. A useful model of the heart is to imagine it as a house. The myocardium and valves are the structure, the coronary arteries are the plumbing, and the specialized conduction system is the electrical wiring. Most heart issues can be similarly divided. Issues with structure is heart failure. Plumbing problems yield heart attacks, PK myocardial infarctions, and electrical problems are arrhythmias and cardiac arrest. Normal electrical signaling begins when negatively charged cells in the sinoatrial node depolarizes, which kicks off a wave of depolarization down the electrical conduction system. The wave passes through the atrioventricular node to the bundle of His, to the left and right bundles, and finally to the Purkinje fibers. This electrical signaling causes a nice, coherent contraction of the heart muscle that effectively pushes blood where it's supposed to go. When this signaling system has issues, the heart cannot contract properly, and oxygen transport stalls. The heart's electrical signaling can actually be measured. This is what an electrocardiogram does. Each component of the EKG informs us on what is going on in portions of the electrical conduction system, from which we can infer how the heart is contracting. An EKG strip for when the heart is functioning normally, called sinus rhythm, looks very different compared with, for example, supraventricular tachycardia or ventricular fibrillation, which kills you. For the past 70 years, people have been making implantable devices which can help manage the heart's electrical system, saving countless lives in the process. Boston Scientific is a leader in making these cardiac devices, and was kind enough to connect me with Dan Goldman, the Vice President of R&D for their rhythm management team, to talk about the electrical problems in the heart and how their devices, like the subcutaneous ICD, are able to improve outcomes for patients, as well as the technical intrinsics on how these devices work and how they might improve in the near future. A small disclaimer, people spend years studying what I just breezed through in 100 seconds. Please check the links in the description for much more detailed walkthroughs on how this works. Yeah, so Dan, thank you very much for coming out. Could you tell me a little bit about yourself?
Yeah, you bet, Bobby. So my name's Dan Goldman. I am the Vice President of Research and Development for Boston Scientific Cardiac Rhythm Management. And so our Cardiac Rhythm Management Division is responsible for devices that treat arrhythmias. So typically pacemakers, implantable defibrillators, resynchronization devices. That's kind of the field, and we can talk hopefully a lot about that. I've been in this field for almost 30 years. So I started off at JPL. I'm an electrical engineer, although a lot of the electrical engineers on my team would laugh at that statement. But I'm an electrical engineering by training. I went to Rice University. I went to JPL out on the West Coast and worked there for about 4 years. Got my master's degree from USC while I was there. And then I joined a small company called Ventritex, which was a startup in the CRM space. And that group of really brilliant people developed really the first modern defibrillator. Not as modern as today's, but a lot of the features that people kind of count on and have for years. And that device was approved in 1993. I was at the company for a week, and we got FDA approval, and everybody around me was suddenly very happy and rich, and I was just, a knuckleheaded quality engineer, right? So anyways, I've been in the industry ever since because I just love it. I love what we do for patients. I love the technology, and I love the people that are attracted to the field. So So I was at Venturetex for about 4 years, and then I joined what was then Guidant here in Minnesota back in 1996. And I've been with the company ever since. And we were Guidant until 2006 when we were acquired by Boston Scientific. So, and I've been in a lot of different jobs, but mainly in R&D, a little bit of time in manufacturing.
Just out of curiosity, so JPL is Jet Propulsion Laboratories, right?
Yep.
What were you working on there?
So I started as in reliability engineering. So doing a lot of circuit analysis, worst case analysis, part stress analysis, FMICAs, those type, reliability types of analyses on a number of different spacecraft. Actually, the one actually blew up when it got to Mars. Not my fault. And then the last project I was working on the Cassini space probe, which went to Saturn and was an effective mission.
Oh, wow.
It was pretty cool. So I was doing the circuit analysis associated with the attitude and articulation control system. So pretty cool stuff, but just a different pace. You're working on something that's not actually going to go in. I mean, it's going to spend 6 years getting to Saturn, right? 5 years in development, 6 years to get to Saturn. And I was just looking for something a little more faster paced. And that's kind of why I kind of jumped out of aerospace. Or NASA aerospace, and joined the medical device world. But it was cool stuff. A lot of really brilliant people there.
Yeah, absolutely. Was that a difficult transition for you to make from aerospace into the medical field?
Well, like a lot of transitions, the earlier you do it and the younger you are, the easier it is to some extent, right? And so, yeah, it was I went from being a person who was basically a paper engineer or a computer engineer, doing a lot of analyses on the computer or literally going through paperwork and just doing that, that kind of grind associated with an aerospace program run by the government, to joining a startup where I had like 10 different jobs in a week, right? And it was small, they were just really building some of their, like the quality work. I was a quality engineer. I had never been a quality engineer, right? So I just had to figure it out. But that's kind of, a lot of people have to do that. So yeah, a little bit of a difficult transition, but you just get thrown into it. And if you're a problem solver, if you're an engineer, you figure it out. Right. And they had a lot of great people that taught me what I needed to be taught. But in 4 years, I did 60 different things while I was there. So
could you tell me what drove you to be involved in specifically where you are, which is device cardiac rhythm management via devices instead of managing the heart versus by some other mechanism? Or why didn't you work on some other, this was phrased eloquently. Could you first tell me how you got involved working in the heart compared to working in any other organ system?
Yeah, like a lot of things, it just not happenstance, but things in your life happen that lead you in one direction or the other, right? So, and I will say that as an electrical engineer, and at this point, I'm much more of I'm a classic, management pinhead versus being an engineer anymore. But as an electrical engineer, it's a fascinating place to be, right? I mean, these devices are really fascinating from a number of different standpoints, but certainly from an electrical standpoint, it's really great stuff. But really, so I was a reliability engineer at JPL, and my uncle started working for what the company at the time was called CPI, which became Guidant, which is now part of Boston Scientific, and he was a sales rep. And I remember him coming home talking about, and he was a sales rep on some of the first implantable defibrillators. So it was really only the late 80s when the implantable defibrillator became approved and available in any kind of reasonable usage. And I remember him talking to me about it, and I'm like, holy smokes, this is really cool, right? And it's just, you're saving somebody's life. It's really interesting technology. The field is changing dramatically. It's really dynamic. I mean, so anyways, long story short, I got exposed to the field through my uncle and was able to use a rice connection to basically get into this startup in Northern California.
And you've been working specifically on cardiology at Boston Scientific since you've been there, since 1998, you said?
Yeah, so I've for the most part. So, big companies like ours have lots of different organizations and constructs, and I'm not going to bore you with that. But I've basically been working in the field of cardiac rhythm management. So we're part of the way we're structured, we're part of cardiology, a cardiology group, which includes things like interventional cardiology, products such as cardiac stents, left atrial appendage closure devices, heart valves, etc. That's kind of the mechanical side. And then I work on the electrical side, which is really, there's two big areas in this field. There's what people call cardiac rhythm management, which is, as I said, implantable devices, right? Pacemakers or defibrillators, right? And then we also have an electrophysiology division. So I did some work with that division, and that's all about treating arrhythmias through ablation, typically. So cardiac mapping, and then ablating, different types of ablation procedures to treat different types of arrhythmias, tachycardia arrhythmias. And that's a whole nother field, which is frankly fascinating and kind of overlaps with CRM.
Okay.
That makes sense. So when I say CRM, I'm talking about this. Right?
So if I understand you correctly, there's kind of there's two ways to treat improper rhythms with the heart. One is with kind of a mechanical device, and one is with, I guess, what you call electrophysiology. Is that right?
Well, no. So if you look, I'll back up a little bit, right? So there's a lot of things that can go wrong with your heart, right? But the big buckets would be ischemic heart disease or coronary artery disease, right? That's when, you basically coronary arteries can occlude over time and people they call it a heart attack, but it's a myocardial infarction, which means you get a blockage, you can't get blood to some part of your heart, and then you can either die or you have a damaged heart on the back end of it, right? So that's ischemic heart disease, right? It's one big category, right? And then there's heart failure, which can be, which can come out of ischemic heart disease. It can come out of high blood pressure. All kinds of things can lead to your heart being basically what you're asking of your heart. Your heart can't do what it's being asked to do, and it kind of falls behind. And your body kind of encourages your heart to work harder. And unfortunately, for many people, that turns into this downward spiral, and that's called heart failure. And there's different types of heart failure, right? And then there's arrhythmias, which your heart rate can be too slow, which is less than 60 beats a minute, clinically classified. That's bradycardia. Or your heart can beat too fast, which is over 100. But really what that means is you can have an organized fast heart rate, ventricular tachycardia. You can have ventricular fibrillation, which will kill you, right? And then a lot of people have atrial tachycardia. And so maybe we'll get into a little bit of the heart, so kind of make this distinction important. But all these different arrhythmias, when it comes to arrhythmias, it's really about either devices like what I work on or ablation procedures. Heart valves, stents, even are really meant to address the pumping function of the heart, addressing those types of issues, and preventing and protecting patients from ischemic events, like with a stent.
Just to make sure that I understand, and kind of, forgive me for the oversimplification, but your heart is a pump that needs to move blood around so that your body gets oxygen. And what you said is that there's a few things that can go wrong. So the pump can clog, basically, and that's what you said is a myocardial infarction.
Well, so just to back up. So, your heart's a pump, exactly. I think everybody who's listening to this gets that, right? And I guess a few things at a high level, think about, the right side of your heart pumps blood to your lungs. Left side of the heart, left atria, left ventricle pumps blood to the rest of your body, right? That's probably pretty obvious. Couple distinctions. So the atria of the upper chambers, they're supposed to beat together, and then the ventricles are going to beat, right? As it turns out, most of the blood flow that goes into your ventricles is not pumped by the atria. That's kind of, simplistically people think, pump, 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 right? But most of the blood flow happens passively. The ventricle basically fills during diastole. The atrial contraction only gives you about 20% of that blood flow. The reason that's important, because if you think about it like atrial fibrillation, well, let's stop. So fibrillation is basically what's supposed to happen electrically in your heart is you have a specialized system which is unique to the heart. You have the sinus atrial node, which is on top of your right atrium. A heart. So it's up here, right? And that starts your heartbeat. And most people, you and I, our SA node is going to go off automatically about 60 beats a minute, or maybe higher, whatever, between 60 and 100. And that's going to happen naturally. The action potential drops, the membrane potential drops, and then you basically get depolarization, the action potential, and that starts the heartbeat. And cardiac cells,
that's just an intrinsic property of
that's
that
right.
As SA node.
That's right.
That's just the way the cells are made.
That's right. And all cardiac cells are coupled together through intercalated discs. I think that's how you pronounce it. But anyways, they're specialized in terms of not only, their protein fibers, which allow for contractility, but even how they're connected together. So that once the SA node fires, it's going to go through both atria. It's going to go to the AV node, which is a specialized structure between your atria and your ventricles. And that conducts it down into the ventricular conduction system, which goes through the His bundle and then through the bundle branch, the right and the left bundle branches, which go into the right and left ventricle. It's important to note that SA node also will go off automatic. I'm sorry, the AV node will also go off automatically at a slower rate, as you can imagine, than the SA node. And it also has a delay. And that's it basically delays the signal. That's important. It allows the atria to complete their contraction. And it also prevents signals from going directly from the atrium into the ventricle on a one-to-one
And
basis.
why is that a good thing?
So if you have a lot of people get atrial fibrillation. So what I'm describing is the normal heartbeat starts, as I said, an SA node is conducted through the heart, through this, through the AV node and through the bundle branch, and you get a nice wave of depolarization and a nice regular heartbeat, organized.
And depolarization is just the kind of electrical signal flowing.
Yeah, that's what happens when you get when it contracts. You get tons of calcium that gets pushed out, and that's when the fibers, the protein fibers, lead to contraction, and that's electrically and mechanically the thing that happens. That's important, right? And then it takes some time to recover. There's a refractory period, so forth and so on. But that's organized. In fibrillation, basically every cell is going off on its own for a variety of reasons. And when that happens, there's just this disorganization. Every cell's doing its own thing. You don't get a nice heartbeat at all. Your heart's quivering. And so what a defibrillator protects against is basically when that happens to your ventricles, you're going to pass out and you're going to die, right? And so that's what a defibrillator treats, either external or implantable in this case. Now, if it's in the atria, it's a much less serious for the reasons I discussed. One, your atria are important. You're going to notice, if you had atrial fibrillation, you're likely going to notice, because you're going to notice that missing 20%, right? But if you're less active, if you're elderly, my father, for example, was in AF, he didn't even know it, right? Just because you're just not placing as much demand, it's complex. But you may not even know if you have atrial fibrillation. And atrial fibrillation is going to lead to basically it's going to, not all those signals get coupled because of the AV node delays things, right? And so that's good, because if your atria are going at 250 beats a minute, for example, if that's in your ventricle, you will die. But the AV node kind of protects you from that happening. Does that make sense?
Yeah, so just to recap, so you have kind of the top and bottom of your heart, and a normal heartbeat is kind of like lub-dub. So
Yep.
atria contracts, ventricles contract. In atrial fibrillation, your top part of your heart is kind of flubbering around,
Right.
But that's not such a huge problem because you lose about 20% of volume flow into your ventricles. But if your ventricles are doing this, then you don't have any blood going through the rest of your body.
That's exactly right. So atrial fibrillation is, it's okay acutely. It's not great because it leads to sometimes atrial fibrillation leads to heart failure. For a lot of patients, you would feel it. You're going to feel your ventricles are contracting kind of almost randomly, not at a lethal rate, but it's random. That's not going to be pleasant, right? You're not going to like that, right? And then, as I said, chronically, it's not a great heart. It's an ineffective heartbeat, so it can lead to heart failure. You can also see blood. While your atria is doing this, particularly we're talking your left atrium, you can get blood pooling. And then you can get a blood clot. And then next stop after the left ventricle is the brain. And so that's why you see patients that are in chronic atrial fibrillation are typically on some type of therapy to deal with blood clots, whether it's an occlusion device in the left atrial appendage or just blood thinners.
What causes either atrial or ventricle fibrillation?
Well, that's an interesting story. So I guess, ventricular fibrillation, that's when all the cells are kind of doing their own thing. So there's different things that can lead to it. Classically, I suppose, what was pretty prevalent and is a little bit less prevalent, but what was historically pretty prevalent is you have coronary artery disease, you have a myocardial infarction, part of your left ventricle typically is damaged and basically electrically dead, right? And so now your circuit, you think about your circuit has a big dead spot in it, right? And what can happen is signals can kind of go back. You can get what's called a reentrant circuit, where rather than having a nice heart, think of the electrical wavefront going a nice one front, it can kind of circle back on itself. And what can happen is you can get a ventricular group of cells depolarizes, repolarizes, maybe 200 milliseconds later is out of its refractory period and can be stimulated again. And it gets stimulated because of this rogue pathway. And then that can lead to what's called ventricular tachycardia, which is a very fast heart rate, which is going to be organized, and that can degenerate into fibrillation. or it can immediately go into fibrillation, where basically every cell starts going off on its own. Does that make sense? You can also see that sometimes with, not so much with ischemic heart disease, but with heart failure, where your heart gets big and stretched, it's overtaxed. Your body tries to get your heart to work harder, and in so doing can actually worsen the condition. You get fibrosis. Basically, both your mechanical and your electrical substrate of your ventricle changes in a bad way, and that can also lead to what can cause a reentrant circuit or fibrillation. Does that kind of make sense?
Yeah, I think so.
So when you have ventricular tachycardia, if it's organized, which is you got just a reentrant circuit, it's organized. Every cell, there's at least a circuit, and every the wavefront is deterministic. It's way too fast, and it's not going to be good, and it could degenerate, but at least it's organized. You can sometimes break that with rapid pacing. So our devices do that, right? So they'll deliver what's called anti-tachy pacing, which is delivering pacing kind of a little bit faster than the actual arrhythmia, and it can basically break the circuit.
Okay.
However, once you get into ventricular fibrillation, it's all disorganized. The only thing you can do is like Control-Alt-Delete, right? Which is you basically have to capture every cardiac cell and shove all the ions one way and then all the ions the other way, and that's a defibrillation shock. And it basically resets the heart electrically, which works.
To step back just a little bit, tachycardia is defined as a heartbeat over 100 beats per minute.
I think that's the clinical definition, but obviously you can have what's called sinus tachycardia, which you're going to have if you go for a run, right? That's fine.
That was exactly my question so what's the difference between I go for a run, my heart beats 180 beats per minute, I'm obviously fine. What's the difference between that and what you're describing? Yeah,
so I guess it's like it's a malfunction, so to speak, right? It's typically going to be in some patients. I mean, our devices do this. They'll try to sense between what looks like a sinus tachycardia, which is kind of that to the device, because the device not only measures rate, but also modern devices can look at morphology. So we can actually you can do a template of what the QRS looks for in a normal kind of heartbeat, and the device. But anyways, in general, you're going to have sinus tachycardia is typically slower than a ventricular lethal or a malignant arrhythmia. And that's caused by non-normal, some issue in your heart that's not related to normal function. Sinus tachycardia is normal function. The heart rate, the heart morphology, the QRS morphology looks like sinus morphology.
Yeah, I understand what you said. I guess at kind of to first order, you could say, well, if I'm detecting a rhythm of 300 beats per minute, then that's clearly not sinus tachycardia.
For sure. Yeah, for sure. We'll look at the atrial rate versus the ventricular rate. We'll look at morphology, and then, but typical devices, a lot of it's just the rate cutoff. To your point, which is basically anything above 220, that's really fast. That's VF, ventricular fibrillation, and you're going to shock it.
I see. Okay, great. And then focusing it in the heart, I kind of asked you this before, and I just want to make sure that I get to a place where I understand. You have a heart, which is first order a pump. I've heard it described as there's kind of plumbing problems, and then there's also electrical problems.
Right. Yeah.
And my question is, are there any electrical problems that can't be solved with a device of some kind?
Interesting question. Well, there's always going to be some problems, right? But typically electrical problems. So I guess break it down. If you have bradycardia, and that's typically a problem with your sinus node, sometimes a problem with your AV node. You'll get AV block, right? Where either the SA node's not working, which means your heart doesn't beat fast enough, or it doesn't get conducted to the ventricles. There's really not a lot of good interventions for that besides a pacemaker. There's really not drugs you can use. A new heart valve won't help you. You get to replace, if your body's, basic pacemaker, autonomous pacemaker system's not working, you need to get a pacemaker. Now, I'll note that the vast majority of patients won't drop, if their SA node fails or if their AV node fails, you just won't keel over. Because there's cells in your ventricle that will fire automatically. Now, they're only going to fire 20 to 40 beats a minute, so that's not great, right? But at least it will. You can stay alive long enough to get a pacemaker, right? If you follow me, right? Well, so for bradycardia, you pretty much need a pacemaker, okay? If you have tachyarrhythmias, a number are caused by different things that happen in the atrium around the tricuspid valve, around the mitral valve, really more the tricuspid valve. And there's all kinds of different, there's probably 50 different things that can go wrong from an atrial tachycardia standpoint. And those can often be treated very successfully with ablation. Like there's a connection, there's an inappropriate connection, there's a slow pathway and a fast pathway. There's a pathway into the ventricle. If you burn that tissue or freeze that tissue, you can cure that atrial tachycardia, which once again is a fast heartbeat, but it's regular, right? A whole nother bucket is atrial fibrillation. Very common as people get older. People don't know exactly what causes it, right? It's, a lot of age-induced maladies can lead to it. A lot of different things. It's very, very prevalent. And there's different ablation techniques typically to treat that. And they're not as successful. They're like 80% successful versus, a much higher success rate on atrial tachycardia. Does that make sense? So historically, for atrial fibrillation, there has been technology that's been developed to actually cardiovert or shock the heart to treat the atrial fibrillation, right? In fact, we bought a company, Boston Scientific bought a company years ago that had this capability, but it never really caught on because it's important. The defibrillation shock is really painful, right? I mean, you see it.
Like physically painful.
Physically painful. It recruits all the muscles in your chest, right? And you see it on TV with the paddles or what have you, and it's kabam. Now, sometimes, you'll have a patient, they'll pass out, they have syncope because they have VF. They'll pass out, they'll get shocked, which is nice because they're passed out, and they wake up and they're like, what the hell just happened? Right? So, right. I mean, I worked with somebody he was a sales rep, has a famous story where he got called in, had to go to the clinic. The patient and the patient's wife were irate, really mad because he passed out, busted his nose open on the bathroom floor. They want to know what happened, what was wrong with your damn device that he passed out. And then, of course, when they show him the rhythm strip, no, actually, he died and the device saved him. That's what happened, right? So, anyways, the point is, I'm sorry, I'm digressing. The point is the shock is painful, right? Defibrillator patients they go to support groups sometimes, right? And, because it's really, you can imagine something inside you that's going to go off, right? And when it goes off, it's going to hurt like hell, right? So, and unfortunately, once you recruit the muscles, so a defibrillation shock, an internal defibrillation shock is about 40 joules. Think about 700 volts, okay? It's a big event, okay? Now, but the problem is it's going to be painful. There's not a huge difference in pain between 2 and 40 joules. So even a small shock to defibrillate the atria, it's going to hurt. And as I said, ventricular fibrillation is going to kill you. So if it hurts, well, that's just that unfortunately that's what's going to happen. Atrial arrhythmias are not acutely as dangerous, and so, anyways, that kind of cost benefit ratio wasn't seen as acceptable in general. So that's why atrial fibrillation is typically treated with some type of ablation or drugs versus a device.
And just to be clear on terms, I've understood an ablation to be basically like the electrical engineering analog would be you have a short circuit and you just go along cutting wires such that the short is eventually removed. Is that?
That's not a bad way to describe it. It just gives you a little more color. So, for example, it's believed, or it is the fact, that a lot of atrial fibrillation kind of stems from your pulmonary veins that kind of come in the back of your left atrium, right? They kind of, the precursor for fibrillation happens somewhere electrically in the pulmonary veins. And so a common technique to treat paroxysmal or even persistent AF, it can be isolation of those pulmonary veins. So you basically just burn or freeze the tissue around each of those pulmonary veins to keep anything electrically that's happening there from coming into the left atrium. So that kind of makes it a little bit more real in terms of what's done.
Do ablations cause any damage to the heart? Is the damage noticeable to heart function?
Great question. Maybe. I mean, certainly sometimes when physicians are if there's some kind of AV reentry where it's they're ablating a small portion of tissue. These EPs, electrophysiologists, are the specialized field of cardiology that our customers that we either on the ablation or the device side that we typically deal with. electrophysiologists, right? So they get their cardiologist training, and then they go to school some more to get their EP degree, right? And so these guys and gals are just brilliant, and they really, they map the inside of the heart both from an anatomic standpoint as well as an electrical standpoint. And so we have systems that help them do that. And then they can isolate often exactly what's going wrong through both mapping or even just their timing, the ECG signals or in their timing analysis. And then they can break that circuit. Typically, that's not going to cause a problem, right? Sometimes when they're chasing atrial fibrillation and you can end up damaging a lot of the atrium, and you may solve the fibrillation, but maybe the atrium's not going to work that great. Now, that can definitely happen. Ventricular tachycardia, that's another question. So sometimes you can map the ventricle and figure out what's going on that's causing this reentrant circuit, this ventricular tachycardia, and then you can, burn or freeze. Well, it's in case of the ventricle, it's always burn. You can burn that location. People, that's, you got to take things really seriously in the ventricle. So it wouldn't be uncommon to have a patient that has ventricular tachycardia. They get that ablated, but they get a device as well, an ICD, just in case.
I see. Why do you only burn as opposed to freeze in the ventricles?
Oh, it's kind of the history. I think I'm not sure when the first ablation was back in first one was 1981, and I think the first RF was 1998, or the first AF ablation was 1998. So the classic ablation, the historic ablation system is RF, uses high radio frequency, generates enough heat that kills the tissue, right? That's the typical modality. That's what the catheters and the generators are all designed to do. More recently, cryoballoon technology has been used kind of from an anatomic standpoint, an anatomic ablation, meaning that you don't really worry about mapping so much. You just go to each of those pulmonary veins I told you about, put the balloon in the os, and freeze. And so I guess cryo could be used in the ventricle. There's just never been a system designed to do precisely that. And it's most ablation procedures are atrial versus ventricular for probably some of the reasons we talked about, just given the risk factor associated with the ventricle.
Got it. And when you say mapping or map the heart, can you say more specifically how does that work?
So let's see, this is turning that. Oh, there it is. So so what you basically do is this is like a 64 electrode mapping catheter.
Mm-hmm. Okay.
And basically, this is connected to our mapping system, which is a really kick-ass piece of technology. And you basically record all the electrical signals. And this has a sensor in it, so a magnetic sensor in it. So it can basically, you get like a shell of the heart from an anatomic standpoint, and then you can overlay that with the electrical signature of the heart. Fibrillation doesn't work that great, but certainly for the sinus rhythm or even organized tachyarrhythmias, you can basically allows the physician to map the wavefront of the heart.
Okay. And
it's actually that's worth a whole nother podcast that I'm not the best person to talk to you about. But it's a newer field in pacemakers, right? Our typical customer, Boston Scientific, EP customer, is much more excited about ablation than pacemakers because they've been around.
Okay, I see. Huh. And so this device goes up through someone's vein, right? And into the heart. Is that how it works?
Typically you go through the femoral vein, right, into the right atrium, and then you can either stay on the right side or you can cross the septum. So your septum between your two atria is very, very thin, and so easy for me to say. But you use a needle or some other type of technology to basically allow you to cross the septum, and now you're in the left atrium.
Huh. How is this controlled when it's inside of the body? Because it looks like just a loose wire. I don't.
Yeah. So that's our job to provide technology that allows you can move it around, right?
Oh, I see.
Okay. You can change the basket. So that's kind of our job to make all this stuff work. Which I always say, I'm a double E, so this is boring, but it's actually not boring, of course. But the other thing I'll note is one of the fascinating things I didn't really realize this till I got in this business, but physicians are more than just smart people, right? part of being a really good physician is you need to have good hands. You have to be a bit of a craftsman to use this technology. And obviously it's our job to make that part of the job as easy as possible. But I guess shouldn't underestimate both of course they're, tend to be brilliant, but they also tend to be craftsmen or craftswomen, so to speak, when it comes to this type of technology.
Absolutely. It's something, I started out more on the theoretical side of things, and everything is, you just think about it, and then someone else is going to go and make it, and it's fine. But that actual, that leap from having it can be perfectly designed, but physically machining something and getting all the intrinsics to physically work is so difficult.
No, it is. I'll tell you, we do a lot of the innovation in the medical device field comes from startups. Like I was at a startup there at the beginning of my career, but basically the startup's job is to take. Now that's applied research. It's not research. It's pretty applied. But they're going to try to solve one problem with an answer, with the technology, and basically prove the viability of that technology to do what they say it's going to do. That's all great. And then they get, then the company gets purchased and everybody makes a lot of money and everybody's happy, right? But turning that into something you can manufacture at high quality and at high scale, thousands of catheters, hundreds of thousands of devices, and do that where it works 99% of the time. And that's all a big part of what the challenge for a company like ours is, right? It's not just about inventing. It's about allowing that technology to scale safely and profitably.
Right. Absolutely. And one other question about your mapping device. You mentioned that there's a magnet sensor.
Yep.
Is that for like an induced magnetic field from the electrical activity?
It's basically used for mapping. So that there's an external system that applies the field, and then you can register where the catheter is, basically based on that sensor.
Oh, so you have an applied external magnetic field.
That's right.
And sorry, so what does that allow you to see?
That allows you to know it allows you to know where the catheter is.
Okay. In relation to just the rest of the heart.
Yep.
Okay. So one more kind of basic level question, and then I want to dive into the actual devices with you. But this is, as an electrical engineer or maybe as a physicist, could you tell me how you see the heart, or kind of what are the important parts of the heart for what you do?
Yeah, so it's really defibrillation is different than pacing, but if we think about pacing, it's really about how do you capture heart tissue. So it's really about creating a strong enough electrical field, like a volt per centimeter, I think is the threshold, a strong enough electrical field to create enough current to basically start that depolarization wavefront. And so that's it's the heart electrically. It's really complex when you get down into the calcium going one way, the potassium and the sodium and all the different channels and the protein reactions. And it's real, but you don't really need to know that to do my job or to do our job to some extent, right? It's really about getting strong enough voltage, strong enough electric field to induce the current to get to start the heartbeat, whether it's in the sinus node or in the AV node or directly in the ventricle. And you can model that through, if you think about a bipolar pacing model, you'd have the resistance of the cathode wire, the lead, right? And the business end's going to have two electrodes, the helix, cathode, and then the anode ring, right? So it's basically the wire resistance, the lead resistance. It's the electrode interface, really complex space, right? You want low geometric surface area, but kind of a high porous surface area to make sure you don't have too much polarization. In other words, you don't want voltage to build up on the electrode or ions to build up on the electrode, which will end up blocking your pulse anyways. But so that you can model that interface as like a resistor and capacitor. And then kind of coming around, and then you have the actual impedance in the body or in the heart between your two electrodes, and then kind of the same thing going back the other way. I don't know. Is that so? But it's not, as I said, it's incredibly complex, but you basically can model it pretty simply.
Are there kind of typical values for body resistance or heart capacitance? What kind of scales are we working with here? Are we at milliohms or ohms?
Yeah, I think more ohms. So like a typical pacing impedance, like if I put this in your right ventricle, well, you wouldn't want me to do that, but you get the idea. If you put this in your right ventricle, think of the pacing impedance. Think of that overall impedance is about 800 ohms. Okay, and most of that is either the two wires that are required, and the electrode impedance, and then the body impedance is actually pretty low. And I don't know what the capacitance is. It's like 40 microfarads or something. Something like it's. But that's kind of what we're talking about.
And then I'm imagining that this differs from each individual heart has a different kind of threshold for what you need in order to get that signal through. Is that correct?
I would say normal cardiac tissue it's not going to have that much variability, but of course, to your point, depending on where the lead is, how where the electrode is placed, is there scar tissue? There's all kinds of other things that can lead to different ranges. But in general, and that's why in general, your pacing impedance is going to be anywhere from 500 to 1500 ohms. And different leads have different electrode designs and have different kind of inherent impedances. But, your pacing impedance is going to be somewhere around there. If you get up to 2000 ohms, something has gone wrong, right? And it would be unnatural to have something like 300 ohms. That would be a bit of a surprise. And then defibrillation impedance, which is a different, that's going to be the impedance between the can and a couple coils. So this is a defibrillation lead. You see that? Okay, I don't know if this is a good venue.
Yeah, could you hold it back just a little bit, just so I can see the whole?
Yeah, so you can see right where I'm holding here and right here, you can see you kind of have a coating over the coils, but they're basically electrical coils, and that you generate the voltage basically between the coil and the can and this distal coil, and that's where you apply your 700 volts. And that impedance is going to be 70 ohms.
It sounds like a relatively straightforward, like from an electrical engineering standpoint, it sounds like and I understand that there's complications and,
Sure.
very fine details that I'm not close to understanding, but it sounds like on the surface, it's a relatively straightforward, like circuit diagram.
It is. There's a lot of complexity, and that's where, industry has evolved fairly dramatically, at least in the early years when it comes to electrode design, coming up with an effective electrode design that balances all the things you need to balance. But yeah, in general, it's V equals IR gets you a long way when it comes to things like pacing. Now, the complexity associated with sensing a 200 microvolt signal, designing all the stuff that goes into the algorithms to make sure that you're pacing the atrium and the vent. Actually, dual chamber pacing is one of the more complex things that is done from an algorithmic standpoint, doing that safely. So there's a lot of complexity. Yes, when it comes to the actual, do I capture the heart with 1 volt per centimeter or 6 volts per centimeter for defibrillation? I think that's the number. That is kind of straightforward. Just getting to that point is the hard part, I suppose.
So thinking about devices, there's defibrillators, and there's pacemakers. Are there any other classes?
Yeah, sure. There's the first pacemakers, first implantable pacemakers, that whole activities, that whole invention. A lot of folks were working on it, as you can imagine, in the late 50s, early 60s, and kind of progressed from there. Then there's defibrillators that Dr. Morawski and Dr. Moore kind of innovated they started in the 70s, but then that came to market in the 80s. And then in the early 2000s, the industry came up with resynchronization devices, which are similar, but pace the left side of the heart, and it's really to treat heart failure. So to back up, if you have, if your heart doesn't beat fast enough, you have bradycardia, you get a pacemaker. Where did I put my pacemaker, right? If you have either really rapid ventricular tachycardia or you have ventricular fibrillation, you get a defibrillator. Now, the early days, you only got a defibrillator if you died and were saved, right? Does that make sense, right? So you have the event. There's not a great diagnostic for it historically, right? So you have the event, and you get rescued, ambulance, somebody has some paddles, what have you. Sometimes you can, once you get into VF, you're not going to convert, but you get rescued and then you get a device implant. That's called secondary prevention. Now, over time, work has been done by my company, other companies, to show, hey, if you basically if you have ischemic heart disease and your left ventricle is damaged, like your ejection fraction is low. So ejection fraction is the percentage of blood that comes out of your left ventricle every heartbeat, right? So if you're healthy, it's going to be 60, 70%. If your left ventricle has been damaged because of an MI, myocardial infarction, classically, then your ejection fraction is going to be low, 30%, 35%. And there's been controlled clinical trials to show that patients, those types of patients, if they get a defibrillator, they'll live longer than if they don't. And that's called primary prevention. That's a pretty big part of the market, particularly here in the U.S. Okay, and then what was determined by a lot of really brilliant people years and years ago was that some patients with heart failure have what's called electrical desynchrony. So basically, the heart's big. You've had remodeling occur, which is not good, and basically on your ventricular depolarization or your ventricular contraction, the right side and the left side are not going at the same time. And so rather than the left ventricle can beat up against an already stiffened wall or what have you, basically that ends up, that electrical desynchrony leads to poor pump function. So, and it's quite often because you have something called left bundle branch block, where that signal is not getting to your left ventricle in time. So your heart fires the right ventricle, and then there's a big delay to get to the left ventricle, and you get an ineffective heartbeat. And so what a resynchronization device does is you basically put a lead, you go in the right atrium, you go through the coronary sinus, and you get into the left ventricular venous system. And you basically put a lead in one of your cardiac veins on the surface of the left ventricle epicardially, and you stimulate the left ventricle, at the same time as the right ventricle, or maybe a little bit ahead or a little bit behind. But the point is, you stimulate the left ventricle sooner than it would otherwise go. And that can, and then studies have shown, these devices were first approved about 20 years ago. Studies have shown that the patients live better and live longer if they get this therapy, the vast majority of the time. Not everybody responds to this therapy, but with the right patient criteria, inclusion criteria, you get really good outcomes. So those are the family of resynchronization devices. They're called CRT, cardiac resynchronization therapy, and they can either be a pacemaker or a defibrillator, depending on a variety of things. Typically a defibrillator, because patients in general, if they have poor LV function, as we talked about, they're going to be more likely to get ventricular fibrillation than others. And so having a device that can both treat their pump issue and with resynchronization, and then potentially treat an electrical problem, so to speak, with defibrillation therapy is seen as a good therapy.
I see. I guess kind of a higher level question. What is the difference on an electrical level between something that defibrillates and something that's a pacemaker?
Yeah, so basically a pacemaker, you're just trying to capture, at that electrode interface, which is quite small, right? You're really just trying to create enough of an electric field to capture those local myocytes, to capture those cells. And then because of the way the heart works, you're off to the races. It will stimulate, it'll create a wavefront and will stimulate the rest of the heart. That's all you're really trying to do. But you just have to get, I don't know what the number is, but it's just that local area you're trying to stimulate, right? In fibrillation, as I said, let's say it's in the ventricle, all these cells in here are just going off on their own. The wavefront is just this jumble, right? And that's why when you look at the ECG of a fibrillation, you see noise. It looks kind of like noise, right? Not organized. So there you need to capture every cell, basically every cell at the same time. And so that's why you need much higher voltage, a much greater electric field to basically capture every cell at the same time.
My understanding is also that defibrillation is like a rare event, whereas a pacemaker, I don't know if a pacemaker does it. Do you need one beat from your pacemaker for every heartbeat?
Oh, yeah, okay. Yeah. So every indication is different, right? Some patients only need pacing occasionally. Some patients have an AV block, right? And it doesn't happen all the time, but when it does, it sucks. So you want that. So you'll see pacemakers go, rarely to 100%. Some patients have complete heart block, and if you don't pace the ventricle, nothing's going to be going on except this escape rate, which is not going to be pleasant, right? Or some patients have a bad sinus node, and you better pace it. So it can vary, I guess, is my answer for pacemakers, right? For sure. For resynchronization therapy, that's one where it's not going to work unless you pace, and so you'll see resynchronization pacing is typically you want that to be a high percentage of the time. Okay. Now, yeah, you're right. For fibrillation, better be rare, or the patients the prognosis is poor, and so a lot of patients will be on medications to try to address their arrhythmias, and the device is really there as a backup because medications for rhythm or rate control aren't going to be 100%. And so patients, I don't know what the average shock rate is exactly, but once every, one or two times a year, 1 or 2 times every 5 years. I mean, it's a rare. The good medical management on a reasonably healthy patient is not going to mean they're going to get shocked all the time, for sure, because that's if a patient requires a lot of shocks, their heart's in pretty bad shape.
I see. From a technical standpoint, how different are these devices? Whether you're talking about a pacemaker, it sounds like all of them have some mechanism to deliver electrical signal, some mechanism to measure electrical activity, and then I would guess, some sort of battery and some place to do the algorithms.
Think of a defibrillator as kind of built on a pacemaker, right? So your pacemaker is going to have your battery, 3-volt battery. It's going to have a microprocessor. Now, this is modern day, not back in the old days, but it's going to be a little computer, microprocessor. It's running diagnostic, has hundreds of features, can do, dual chamber sensing and pacing. As I said, lots of different diagnostics, both for the device and even for the patient. It has a telemetry capability, which typically means both kind of a short-range inductive telemetry, as well as a long-range radio frequency telemetry function. And it's, so in all the circuitry associated, do I even have, well, anyways, you get the idea. That's a pacemaker. The defibrillator is kind of built on that. And so what you have to add with the defibrillator, along with, you need specialized sensing algorithms that are different, right? But from a hardware standpoint, the obvious difference is you need the ability to charge up high voltage capacitors to, let's say, 700-800 volts and deliver a shock, which is a pretty big deal, right? So you need high voltage capacitors. I think this device is actually, handy. So here's the inside of a defibrillator, right? And this is the battery. This is the circuitry. Custom, we design our own integrated circuits, as you can imagine, given, Apple's not designing this kind of stuff for anybody else, right? And then these are the high voltage capacitors. So you need pretty big high voltage capacitors to store that much energy. And so I will say, as I said, I started in the business in 1993, and there were really 2 companies that had implantable defibrillators. So my current company, CPI Guidant, was the first company to come out with implantable defibrillators. Then Medtronic, probably heard of Medtronic. They had defibrillators, and everyone else, all the pacemaker. There was tons of pacemaker companies back then. I don't even know the number, but there were, probably 8-9 relevant pacemaker companies, and they were all in a race to develop an implantable defibrillator just because of the need and the market and everything else that you can imagine. And I'll say, just as a testament to, it's not like falling out of bed. A lot of those companies couldn't do it, right? There's really 4, maybe 5 relevant CRM companies right now. And a lot of that culling happened in the transition to implantable defibrillators, because coming up with a reliable, having the right battery technology, the right capacitor technology, and even just the electrical engineering required to charge something, charge up to 700 volts and deliver a 40 amp pulse in this kind of form factor, even back in the old days when it was this big, that's non-trivial, right? And a lot of different things can go wrong when it comes to high voltage. So I don't know if that answers your question, but there's a big jump to go to ICD, to defibrillators. And then going to resynchronization is more about how do you get to the left side? What's that access technology? What's the lead design? And then what's the algorithm design to actually really sense and pace a new chamber? So more of a challenge from an algorithm standpoint and a lead design standpoint than from a core device hardware standpoint.
When we're talking about implantable devices, my understanding is that they're like kind of these things you're holding up get implanted kind of on the left side of the chest, or like somewhere on the high left side of the torso, and then you just have these wires going into the actual heart itself. I guess, is that right?
Yeah. So historically, so typical pacemaker implants going to be up here. Basically, you make a stick. You search for they're looking for either the cephalic or the subclavian vein typically, and they use that as the route to get into the right side of the heart. And then you put your one lead in or your two leads in, make sure everything's copacetic, you have good fixation, then make a pocket here, and the device sits up here. For a similar thing for a modern defibrillator, right? It's just a bit bigger, easy for me to say, maybe a lot. I show people this device and think it's so small that everybody's like, oh my God, you put that in? That's like, this is how big the first defibrillators were, right? So anyways, same kind of thing, you put it up here. Okay. I guess a few things to note. First, on the defibrillator side, as I said, the first devices were this big, right? And just because they're so large, they had to go down here.
Wow.
And the first defibrillator leads were actually like this, and they were actually sewn on the outside of the heart.
Wow.
So what happened? I get jazzed about this because I guess it's my job, right? But what happened? This was back in 1993, we came out with this device, which had a lot of great features in it, but it was still huge, and it still required this, right? And then shortly thereafter, the first transvenous the fibrillation lead was invented, or was brought to market by CPI, right? Which now, okay, rather than having to sew this on the outside of the heart, I can implant this like a pacing lead, transvenously. And so that you can imagine how big a difference that made, right? Now, many more patients could. Before, once you have to start doing this, I mean, you better. These are going to be. It's kind of this. They have to be really sick to merit this kind of intervention, and if they're really sick, that's going to be a pretty risky procedure, right? What the ICD market really exploded, or a lot of patients were able to benefit from the technology once the technology got better. Once you could use a transvenous lead, and then once the devices got small enough, at least somebody my size could get a pectoral implant, right? So back in the mid 90s, so the combination of the transvenous lead and a device small enough to be implanted up here, that really is what kind of enabled a lot more patients to benefit from the technology. Make sense?
Before you had the transvenous lead, you had this patch literally sewn onto your skin?
No. Sewn onto the left ventricle, to the epicardium of the left ventricle, to the heart.
Oh, I see. Okay. And then where was the mechanical device? Where, could you remind me where that was stored? You said like down on your waist?
Yeah, you'd down here and then you actually, it sounds kind of barbaric, but you would tunnel the leads. Yeah, or tunnel down, attach the leads and then tunnel down to the pocket. Now, this technology saved a lot of people, right? It was awesome, but you can imagine that's just a much different proposition than a modern system where, it's all, it's a much less, I guess it's pretty damn invasive, but it's a hell of a lot better than the old system.
Either are better than dying, but wow, the new one
sure.
that's day and night different.
The other thing that happened in the defibrillator world about a little less than 10 years ago was the subcutaneous ICD, which is a bit different. So we may get into this, but kind of historically what's seen as the weak link of these types of these CRM systems, particularly now that the devices have gotten better, device longevities are going to be a decade or more with modern technology. Kind of the weak link historically has been the leads. Just because your heart's beating a lot, it just gets a lot of fatigue over the course of time, and there's a design window. You can't have the lead, so the lead has to be safe for chronic use and well as acute implants, right? It can't be too stiff. You don't want perforation. You don't want dislodgement. There's just a lot of things that go into lead design, and you have to make compromises. And leads are better and better. We're really proud of the leads that we make, right? But in general, I think transvenous leads are seen as at least electromechanically the weak link of a system. So if you at your age got an implant today, those leads aren't going to last the rest of your life, right? You can replace, and I guess either is the device. The device has a battery, but a device replacement is more straightforward than a lead replacement, right? Extracting leads is complicated, and it can lead to bad outcomes sometimes. So leads are problematic in that regard. Then you have a lead crossing the mitral valve. The tricuspid valve. That's not always great. It's a potential route for systemic infection. If you get a pocket infection, now you have a conduit into the circulatory system, into your systemic. You can lead to a systemic infection. So I'm not trying to, we're really proud of our system. We think they're good, but transvenous leads can have issues. So about 10 years ago, a system was developed. The sub-Q ICD was developed, which basically goes right here in your flank. And then you basically have, once again, you have to tunnel the electrode, but it's subcutaneous. So it's not in the heart. It's just it's under the skin, kind of against the fascia, up against your sternum. And you can't really pace, you can't do normal bradycardia pacing, but you can defibrillate without, protection without touching the heart. You don't have anything in the venous system. You don't have risk of systemic infection. And so for patients that just need protection against sudden cardiac death, this can be a great solution.
They're called subcutaneous ICDs, yeah. Right? Is it more difficult with those to detect when you need to defibrillate?
So that's an excellent question. So a lot of the invention or innovation that went into the development of the SICD was dealing with that different vector, that different signal you're getting from the heart, the potential for more mild potential. It's more of a far field signal versus the intercardiac signal. So absolutely. The system's really great at detecting a VF, a ventricular arrhythmia from a supraventricular or atrial arrhythmia. So there's a whole, reducing, as you can imagine, we talked about how painful a shock is, right? It's one thing if you get shocked and you need it. Well, okay, right? But, these systems aren't perfect, and sometimes the device will deliver a shock and you don't need it. And that's bad, right? And so driving down the inappropriate shock rate is a big part of what's happened in the last number of years. And fortunately, it's quite low. It's like 2% or so of the time. But that's an important factor. And, we've a lot of the innovation that happened originally, and since we purchased the company 10 years ago, is going into making the sensing performance with this device equivalent to a transvenous device. And because of that, because of that work, it's in the same ballpark today.
That's great to hear. Stepping back to the transvenous leads, so it's clear to me, when you talk about device lifetime, the issue is the battery. But with the leads, what is the problem over time? Is it just like a mechanical degradation of the metal? What's going wrong with the leads?
Yeah, it's a good question. So it's a lot of different things can happen. It tends to be just classically, there can be issues in the pocket depending on where the device. This is the wrong device, but you get the idea. But with just if perhaps there's a coil. Perhaps the lead gets coiled up, and you can get can on lead abrasion. There's all kinds of different flex points. As you go into the heart, where it's actually implanted. We model all that, and we have fatigue testing protocols, as you can imagine. But you basically have to test. You basically are checking fatigue here. You're checking fatigue here, maybe where the suture sleeve is, and then you're going to do fatigue testing here, buckle test, all kinds of basically mechanical fatigue. Create the right kind of fatigue environments to test the lead, and you can get both silicon or polyurethane, the actual insulation material can fracture, the coil can fracture. All those things can happen, and that you have to try to design around. And the different materials have different characteristics, and we frankly have had to learn as an industry. Some of the early choices on polyurethanes, they look good initially, but over the course of 5-10 years, you started to see pretty significant degradation and potential failures.
Absolutely. A couple electrical questions for you. I was reading a little bit about this, and I came across the idea that leads should be high impedance, but I didn't really get an explanation on why that needs to be true.
Yeah. So I think that gets well. First of all, you want high impedance because V equals IR. You'll have less current flow in general, and so you'll have less drain on the battery. So you want now, but that impedance can't come at the. It doesn't do you any good to have high impedance if it leads to higher. If you need more voltage, because then it defeats itself, right? So you don't want to make the wire higher impedance, right? What you want is you want that electrode tissue interface to, as I said, facilitate high current density while having good polarization performance. So it's that kind of electrode, the electrode tissue interface needs to be both kind of high impedance, but also effective at creating the appropriate current density, if that makes sense. And so, so that's the key. Is that it really comes down to that electrode design.
And so I understand why you'd want basically a high electric field at the junction. What do you need high current density for? Like, I don't have a good model of how you're actually propagating a signal.
Yeah, you're just trying to. It's really about just creating the right ion flow to trigger the action potential of the cell. So you get that action potential below 60 to 70 microvolts or millivolts. I'm sorry, and you basically that you're just trying to create it. As I said, that that pacing pulse. You just want to recruit enough cardiac cells to activate the action potential sequence, and then now you're off and running.
I'm just trying to understand very specifically. You have your lead, which is going to have some high voltage associated with it when you send a signal, and eventually that's going to lead to your heart beating. And I'm trying to understand exactly what's happening at that junction of, is it an electric field that's pushing sodium ions and calcium ions around, or like what's happening exactly at this interface?
I think that's a good way to. I mean, obviously, it's ion flow that's going to conduct the current, and basically, the electric field is going to create enough ion flow that the cell membrane's voltage drops to the point where basically the cardiac depolarization action potential kicks in. And I'm obviously I'm not great at describing that, but that's kind of that's at a high level, that's what's going on.
No, I think that's helpful. So jumping back to the technical side of devices, could you talk with me about what some of the design challenges are? I mean, there's some obvious ones, like you want high battery life, and we just talked about the whole issue of leads, but are there others that are non-obvious?
That's a good question. So for example, I mean, obviously these things have to be highly reliable, and you can't reboot it, right? So these are implanted computers that you can't, it's not like when your iPhone has a glitch, or even your laptop has a glitch, and you say, well, crap, power on, reset it, turn off the power. You can't do that. And so, obviously, I think that's probably an obvious statement. So, a lot of the complexity gets into designing the system so that it has graceful exits. If it can do, if something goes haywire, you can reset gracefully. You can address bit errors due to single event upsets. So there's, I guess, just the general category of dealing with reliability where the device has to manage itself, so to speak, is a really important area. Designing the algorithm so that they're frugal is important, right? We don't run this thing at the same frequency you're going to run a computer, or you have to be very careful how often you use the microprocessor, and all your awesome algorithms have to be designed to be as I said, disciplined and frugal about how much you want to use that microprocessor. So, we have some really cool diagnostics that can go in the device. All those diagnostics, we have a heart failure diagnostic that goes in our device that looks at all these different sensors. It looks at your impedance across your chest. It looks at how often you're moving. It looks at how fast you're breathing. It actually listens to your heart sounds. Really cool, right? And it can take all those signals and blend it and create a diagnostic about how is your heart failure progression going? Are you at risk for a decompensation event where your basically heart falls behind and you're going to have to end up being hospitalized, right? Really cool. But that's not really cool if it takes a 10-year device and makes it a 4-year device, right? And so we have to be smart about how we use the microprocessor, and we have to be smart about a lot of that calculation needs to be done kind of out of the device. Like, we'll pass the data, and then we'll have a remote patient management system. Our web-based application can do some of that processing, right? I don't know. Does that kind of get at some of the things that are?
Oh yeah, absolutely. I'm not sure if you can answer this, but is there a specialized coding language that you use that's, somehow optimized for, battery life and your microprocessor that you use, or can you just use like C++?
Yes. Yeah. Everybody, people will use different things, but we're using, we have, as I said, we just, our ASICs are designed, they're custom ASICs, although we'll leverage a microprocessor core, as you can imagine. We're not coming up with our own microprocessor cores, right? But yeah, people are going to use C++, pretty common, C#. There's just different options, but we're not, we use specialized tools, our testing systems, we'll use, once again, we use standard testing languages, but develop our own infrastructure for actually conducting tests. So it's a mix, but yeah, we're not trying to reinvent the wheel when something out there exists. So when people, when we have to train new engineers, right? It's not so much, sometimes there'll be, we change things and we try not to monkey with it, right? Because monkeying with it can cause problems, right? And so we'll use technology, for longer than you would use in the consumer electronics business, right? And so that can be, so sometimes our tool, our suites, our development suites aren't as up to date as people would like. So that can be a bit of a challenge, right? But most of the learning isn't, do I need to learn a new language? It's just learning how do you do actual firmware development in the cardiac space.
Yeah, absolutely. I had a question for you about batteries. So they haven't gotten super popular, but over the last 10 years, I'd say, there's wireless phone chargers. So basically all phones nowadays, anyways, you can charge wirelessly. Why is this something that isn't integrated into ICDs?
There's a lot of opinions. So I think the first thing is putting a patient in series with their therapy isn't a great idea.
Okay.
As you can imagine, It's one thing, like we have a sister division does neurostimulation, both for Parkinson's and then the historically for pain, spinal cord stimulation to treat pain, right? And those come in a variety of flavors, but a very common system is a rechargeable system, right? But that works for a number of reasons. One, if the patient doesn't charge it, they're not going to die, and the patient, if they want to get rid of their pain, is going to be motivated, right? So, asking a patient to charge their device so it's just not a great. How people are just in general non-compliant, right? They're non-compliant. They're going to be non-compliant with charging. And the other thing is, at the end of the day, this device is going to last you, you can get a little bit bigger and it's going to last you 15 years and you don't have to do anything. So it's the current, I'm not, once again, when we get to the futuristic discussions, I can sound kind of smug and arrogant because maybe I am, but I'm conscious of that. There's not going to be a better solution until there's a better solution, right? But I think the kind of the overall point though is the basic. There's issues with the transvenous leads, like I talked about. It's not perfect. There can be, but in general, both leads and devices are 99% reliable at 5 years. They work pretty well, and so any novel technology has to be measured against what's working today, if that makes sense. And so now when it comes to leadless pacing, that's a newer area. The challenges there are different. It's not as easy to go in and replace a leadless pacemaker. Pretty cool, huh? But it's really cool from an engineering standpoint. It just causes, there's different issues associated with it, right? So I can't, depending on the device, there's not a lot. This has been around. I think the first device was approved in 2016. And so we don't have a lot of long-term data on extractability. And there's different systems. We have a unique system versus the competition. The point is, though, replacing this is a different animal than replacing this. And so I can imagine, it would be really neat if these devices could last even longer. But there ain't much room for a battery in there, right? So now you could make it, a rechargeable cell is going to be less efficient from a volume standpoint. And so, as you probably know, so if I could recharge this, that could be interesting, maybe, depending on, maybe the recharging could be done in a clinic once or twice a year, so you wouldn't have to rely on the patient. The problem is getting this is really deep in the body. Once you get this in the right ventricle, it is in there. And so coupling energy to it is non-trivial. So anyways, I guess what I'm saying is for a standard, I don't see recharging, frankly, happening in the typical transvenous world or even subcutaneous ICD, I think leadless is different. I don't know if it's recharging. I don't know if it's energy harvesting. I think there's definitely some areas to examine when it comes to this type of technology.
Yeah. Could we actually talk about leadless pacemakers quickly? Because it's certainly, I think, I'm not sure if it was on our list explicitly, but I'd love if you could just tell me about them.
So basically, you have a typical pacemaker. Imagine a single chamber pacemaker. So you have this and a lead, right? And the idea is, hey, wouldn't it be cool if you replace this with this, right? Oh, that's cool, right? So why is that cool? Well, first, for the patient standpoint, there's no pocket. They don't even know they have a pacemaker, right? How awesome is that, right? Then you don't have the issue with the transvenous lead, which, once again, today's transvenous leads are really reliable, but they typically aren't. They're not going to last you. They have more issues than the device typically, right? So if I can shrink this down to this thing, don't even know you have a pacemaker, get rid of the lead, you have nothing crossing the tricuspid valve, happy days, right? The implant is much more complex. Everybody has their own system. So there's 2 approved leadless pacemakers. Our leadless pacemaker is in clinical trial right now, and it has a unique aspect, which I'll mention because I have to and I want to. But in general, they're out there, and it's really important to have a really smooth, effective delivery system. So, for example, this is an example of the delivery system. There's a lot going on here to have a nice, safe implant of a leadless pacemaker. Right? Once again, and now rather than incision here, you need to do this femoral vein incision, right? Implant, right? So I think so. But if in the right hands with the right delivery system, I think clinicians enjoy the simplicity of the implant, and they don't have to worry about a pocket. Now this is a femoral implant incision is more problematic than in the chest, but nevertheless, you get the idea. There's some attractive things about it. I think the watchouts are, in general, you're making the device trying to make it really small, and so the battery's small, and so you're going to make some compromises in terms of the feature set on these things, right? The telemetry performance may not be as good. Telemetry takes power, right? You're not necessarily going to get the same kind of telemetry performance. It could be tougher to do remote patient management with these types of systems. There's some nice things from a complication that you don't have a lead, but as you can imagine, in terms of what can go wrong, right? Like lead perforation, like this can perforate through the heart wall, and that leads to tamponade and typically can be managed, but that's not a great outcome, right? Perforation with this is different than perforation with this. You can imagine the difference in severity. Embolization or dislodgement. This thing dislodges, it's whacking around in the right ventricle, that sucks. This thing dislodges, it can end up in it can end up in the lung, right? So these are not common outcomes. I'm just trying to say it's just a different kind of risk-benefit proposition. And then long-term, after this device lasts 10 years, which is kind of what most devices will last, do you put in a new one? Do you try to take this out and put a new one in? There's different approaches based on different device designs. There's still open questions when it comes to leadless pacing. The last thing I'll say is this senses and paces in the right ventricle. Right, VVI only pacing, which means you just pace and sense the ventricle. That's only like 15% of the market. Most pacemakers are dual chamber pacemakers because the atrium is an important proposition from an electrical standpoint. And so this doesn't really address the need for dual chamber pacing. If you have a problem with your sinus node, for example, or you want synchrony between your atrial and ventricular beats. Now there's different solutions. One of our competitors has a trial going on now with 2 devices, one in the atrium and one in the ventricle. They have to communicate. The engineering problems are non-trivial. Not to mention of which the cost of the healthcare system. I mean, there's just it's a complex space, I guess is what I'm saying.
Just to ask you a little bit more about this. So this small little device you have, it looks like it's like smaller than one of my segments of my finger. It looks like tiny. It's really incredible.
It's about a cc. Yeah.
Yeah. Wow. So this goes into your right ventricle. Is that right?
That's right.
And how does it go in there? Does it have to, can you just like slot it in and it will stay?
Yeah. So there's different systems that use different, there's one pacemaker on the market that has a screw, and you basically, through the catheter system, basically are gonna, I don't know how their catheter works, but you basically screw it in. The other two systems, and including our system, has talons. So these are nitinol talons. You can't see that, I'm sure, but maybe. But basically, so in the garage, this thing is going. We call this the garage, right? In that system, is leadless pacemakers there with the talons, your nitinol talons, kind of pointing straight up, and then you press it up against the heart wall, and then you pull. You don't want to push, so we kind of pull off the pull off the catheter, and the talons deploy into the tissue. And that's what we just had a couple implants today, as a matter of fact.
Oh, wow.
One of the things we're really excited about is our system actually can be, as I said, that our SICD goes in with this subcutaneous electrode, which is, it protects against sudden cardiac death, but it can't, just given where that electrode is, you can't pace. I mean, you could apply enough voltage to pace, but the patient's going to feel it. That's not going to be a great answer, right? But what we can do, and we're doing a clinical trial on this, so we'll implant our leadless pacemaker, and basically the device can detect ventricular tachycardia, which is this organized fast rate, and basically sends an interbody signal to the device, to the pacemaker, and the pacemaker can deliver ATP, which is I think it's the first time, and it's happened already in the field. I think it's the first time two devices have actually communicated inside somebody. So, and something good happened. So that's pretty neat. It's called we call that approach modular CRM, meaning you get the module you need given your disease condition.
So you also brought up this idea, or you mentioned single chamber pacing and dual chamber pacing. Could you explain what the differences are there?
Yeah. So in single chamber pacing, which is what the first pacemakers were, single chamber pacemakers, right? And that's really just to basically keep patients alive or at all functioning, because there's some problem where their ventricle won't pace at the right rate for some of these issues. Maybe it's just going at the escape rate. Some patients don't even have an escape rate. The escape rate is what I call this natural ventricular rhythm, right? Some patients don't even have that. So some patients, if the device doesn't pace, they will pass out and die. Now that's fairly rare, but that can happen. And so obviously the first pacemaker patients were probably patients that really needed pacing, right? So single chamber pacemakers typically only going to pace the ventricle. Dual chamber pacers will have two leads, one that goes in the right ventricle, another that goes in the right atrium, and it can basically sense and pace both the atrium and the ventricle. So it can do all kinds of cool things, right? It can, if you have a problem with sick sinus, it can make sure you're firing the atrium at the right rate. It can fire the ventricle at the right delay, so you can program that AV delay, as you can imagine. If it has an AV block, if you have AV block, you can sense the atrium, and then at the right time pace the ventricle based on the right, and that's all it's programmable, and you can all kinds of different options around that. But it's basically gives you the best options, kind of both in the current and the long term for patients that have these arrhythmia disorders, typically.
Right.
Does that make sense?
Yeah. Can you talk about any difficulties with someone that is pacemaker dependent being single chamber paced?
Yeah. So we use pacemaker dependent a little bit differently when it comes, sometimes we use it internally to think, hey, a patient is dependent on a pacemaker, or if they don't have this escape rate. And so our most critical failure modes in pacing are going to be with patients, as I said, this subset of patients that really need pacing, right? But I think the question is probably different. I think that pacemaker dependent, they're defining patients that just need pacing all the time. So maybe a patient that has AV block, for example, complete AV block, is going to need ventricular pacing all the time. Basically, their ventricle's only going to go at this really low rate unless you pace it. And so therefore, you need 100% ventricular pacing. I think what the question is getting at, we now know, versus 20 years ago where it wasn't as well understood, that when you pace the right ventricle from the typical location that you pace, that's not really a very physiologic heartbeat. So you're not, you know what I'm saying? So you're pacing the right ventricle. You're going to pace the right ventricle before you get to the left ventricle. doesn't mimic the heart's natural conduction system, if that makes sense. And so what based on the David trial, and that's a long story, but there's been other trials, but there's a trial about almost 20 years ago. It basically showed that actually patients that are 100% ventricular paced have worse outcomes than patients that are not, in terms of heart failure.
That are not paced at all?
That's right. So basically, in some patients, you basically can induce, sounds dramatic, but I mean, it's the case. In some patients, if you just pace the ventricle 100% from the apex, long-term that leads to, it can lead to heart failure or conditions like heart failure. Now, that doesn't happen with everybody. It doesn't happen all the time. But in general, I think, and it's better than not having your heart beat, right? Or having your heart beat 20 beats a minute. But that's not so if it's my mom and she needs pacing 100% of the time, I would want to look at options outside of just pacing the right ventricle in the apex, which is, if you can imagine, the straightforward place to get a lead is in the, kind of wedge it in the apex of the right ventricle, right? That's a really safe, effective, easy location to get to, or easy for physicians, not easy for someone like me. But as I said, that's not the most physiologic place to pace. So one of the more interesting areas of basic pacing in the last decade has been, hey, how do we solve that problem? Yeah, and so your heart, you have your AV node, and then you have your bundle of His, and then you have your bundle branches. That's all happening kind of here at the junction between the atria and the ventricles, right in there, right? So the observation has been, hey, not for all patients, but for not only for Brady pacing, but even sometimes for resynchronization, if I can basically kind of tap into the heart's natural conduction system, distal to wherever the problem was, I can then use the natural conduction system of the heart to create a much more physiologic heartbeat. Make sense? So there's been a lot of interest in getting to that bundle of His, right? Because sometimes the problem, from the His down, you're in good shape, right? The AV block is north of that, or even sometimes for heart failure, the problem, which is not intuitive at all, but the problem can be addressed with that. Now, the issue there is getting to the bundle of His is not easy. You need specialized catheters to get to that location. Trying to find it is going to be different. It's really small. And so those implants can take a long time. And sometimes I'm just broad strokes here, but sometimes, your thresholds aren't as good, meaning you need more voltage, more energy to capture the heart. That's not great for longevity. Sometimes the long-term lead stability is not as good. And so there are compromises, and there's a lot of people really interested in it. And a lot of people said, I am not messing with that. I mean, because a basic pacemaker implant is like 30 minutes. This is like, and time is money for everybody, right? So physicians to go, okay, I can either do this in 30 minutes, or I can hunt around for the bundle of His, and I may not find it. And having that patient, frankly, a longer procedure is not great for patients, right? There's more risk associated with that, right? And so that's interesting. That's discussion's been around for a long time. I think there's been more interest, at least recently. I think the area of the most interest as we speak today, though, is actually left bundle pacing. So if you go deep enough, rather than go in the eight, pointing to the right side of the heart, that's good. So rather than go here in the apex, can you actually go deep enough in the septum to get to the left bundle, right? So, which is going to be down, I'm sure you've seen pictures of the heart's conduction system, but if you can get to that left bundle, now you're heart wired into the left ventricular system, and you can create, for many patients, whether it's to treat bradycardia or to treat heart failure, you can create potentially a nice physiologic signal. And physicians get super excited about that. So patients with heart failure or patients that have left bundle branch block, the QRS, you've seen the QRS, which is really the ventricular wavefront, the electrical signature of the ventricular.
Could you just describe it quickly? Otherwise, I can just put up a graphic.
Yeah. So there's, your typical ECG has your P wave. I'm drawing here like your P wave, which is your atria. And then you have your QRS, right, which is the depolarization of the ventricles. That's the big signal. That's going to be a number, if you sense it from a pacemaker, that's going to be millivolts in terms of the amplitude. And then there's the T wave, which is your basic your ventricles repolarizing, getting ready for the next contraction. I'll note that one of the issues with sensing is you don't want to sense both the QRS and the T wave, because then you're double counting each heartbeat, and that's a problem, and that's an issue that defibrillators have had to deal with for years, and we're pretty good at it now. But that was at least something obvious you have to deal with. Different frequency content of the T wave and the QRS, which is helpful from an electrical standpoint, as you can imagine. But anyways, so that QRS signal, when you look at it on the surface, which is different than intercardiac, but anyways, when you look at that QRS, if there's a left bundle branch or there's a desynchrony, it's going to be really stretched, like 140 milliseconds wide. It's going to be, that gets to some of the morphology discussion, but it's just this bad, kind of a bad looking QRS, right? And physicians get super jacked, right, when they do this left bundle branch implant and they see that signal go from here to whoop, right? They're like, yes. So that looks much more physiologic. Clinical data is still being gathered, frankly, but I think there's a lot of interest in left bundle branch approaches. As I said, not just as an alternative to resynchronization. So again, remember that resynchronization therapy is basically pacing the left ventricle from the outside. Now, if I can get a similar effect from inside, that's interesting, right? From the left bundle, that's an interesting option, right? But even for patients that need pacing 100% of the time, that could be it's a nice option for those patients. Does that make sense? I think that gets the question I would guess.
Yeah, absolutely. That's really interesting and really helpful. I know I have to let you get going, so I just want to ask you a couple more quick questions. Imagine you're talking to an undergrad who's interested in science and interested in this sort of field. What would your advice be to them? What should they be studying and what should they be doing if they want to improve this field in the future?
Well, yeah, the majority of the engineers in any of these R&D organizations in this field they're not necessarily specialized, right? They become specialized when they join the company. But, we're typically, when we hire engineers, setting aside research, but when we're hiring engineers that are going to do core development, right? They're software engineers. They're software engineers of some type, EEs, mechanical engineers, typically. Those are the majority of. So, in other words, just be a really good engineer, right? You don't have to start specializing in biomedical engineering or some kind of subset of electrical engineering to do what you want to do. If you want to design circuits, obviously steer your career in that direction, or software. But we're pretty good at training and developing standard engineers to learn the specialization that's required to do the work in our business. Now, that said, we have a research group, and the research group's going to be typical masters or often PhDs in specialized areas. Machine learning I should have mentioned that from a futuristic standpoint. There's a lot we can do with improvement in algorithm performance, whether it's even sensing or certainly diagnostics with some of those techniques, and we're starting to do that. But you can't, in our research areas, they're going to be a little more specialized and absolutely be more in the medical field. But for a standard, a lot of our new hires or even experienced hires are going to be you're a EE, a MECI, a software person.
Right. Absolutely. Makes sense.
The other thing I'll say is I have to, it's a different things. We move at a different pace here, right? It's just, we do a hell of a lot of testing, right? We can't, you can't just whip something up and, 2 months later field it, right? I mean, sometimes we do if it's an emergency, but in general, we have to be a lot more deliberate. We have a lot of process we have to follow. Some of that's inflicted by regulation. Most of it is it's just good process to follow. So we come up with something that's going to work like 100% of the time. But it's it can be a little bit, it's a bit of an adjustment to come if you're used to working in the consumer electronics field or just the core, like doing mobile apps or something for just, for games or what have you, right? It's just going to be it's going to be a more deliberate process. There's more paperwork, unfortunately. But that's kind of comes with the territory. So now on the other hand, you get to work on things. And that's why I'll say I'm still doing this because of our mission and because of the people. And this sounds a little bit like I'm being trite, but it is true. I mean, what we do is awesome. Like you're working your ass off every day and people are living better and living longer. And, we make mistakes and it's not perfect, but it's a great mission we have, right? It's cool technology. And, I've been with the company for over 25 years and within R&D, I'm probably within 1 sigma of the mean. In other words, there's a lot of people who've been here a long time, right? Because of how great it is to work on these products, and it attracts really good people. It's, as you can imagine, right? It's challenging and it's fun, and it's anyways, it's awesome.
Yeah, absolutely. I'll give you guys a shout out and say that I follow your Cardiac Rhythms Twitter because you're always kind of posting interesting things on there. That at least even being a physicist, I find it useful and interesting. I know I have to let you go, so I just wanted to say thank you for talking. I'm excited to share this with people, and I think it's really useful.
Enjoyed our conversation, Bobby. So stay in touch, man.